Good afternoon, everyone. My name is Ken Ryer. I'm Vice President here at ComplyAssistant. I'm along with Jerry Blass, President and CEO of ComplyAssistant, and Krystyna Monticello from attorneys at Oscislawski. I'd like to welcome everyone to ComplyAssistant Summer Series webinar number 2. Jerry and Krystyna will be leading the webinar today on meaningful use, the latest evolution of MACRA. But before we get started, I wanted to get through a few administrative details here. This PowerPoint will be distributed to all attendees. The webinar will be recorded, and available links will be sent out to all attendees. All attendees will be muted. You can ask questions by using the questions bar on the right, and they will be answered in the order received. Contact information is provided at the end of the presentation. And now I'd like to turn it over to Jerry for further introductions.
Thanks, Ken, and welcome everybody. We have a great number of attendees today. Very happy to see that. And this is information about me. So we are recording it. We are going to provide a PDF. I'm not going to go into a great deal of detail about me. You'll have it in the follow-up. I want to get right to Krystyna. So Krystyna, of course, is with the attorneys at Oscislawski. She works with Helen Oscislawski. I'm sure a lot of you know both of them. Krystyna has advised and currently represents a wide variety of clients. And you can see them all on this slide, the hospitals, drug rehab centers, etc. Big focus on privacy and security laws and breach notification from both a federal and state standpoint. And of course, obviously, Krystyna is an expert on meaningful use in the MACRA law, and that's why we're here today. The attorneys at Oscislawski are also a go-to law firm for privacy, security, and HIE legal guidance. They are also our partners for all of the regulatory content that is in our software product, also called ComplyAssistant. So with that, I am going to turn it over to Krystyna.
Thank you very much, Jerry and Ken. I'm very happy to be here with all of you today to discuss the latest evolution of meaningful use. Both in MACRA with respect to the proposed rule we received back in May, and of course with respect to some changes that have been proposed for what we could call classic meaningful use on the hospital outpatient prospective payment system side, or OPPS, that was proposed in July. For those of you who have been with meaningful use for the long haul since probably about 2010, you've seen the multiple evolutions that we've gone through with meaningful use. I joked with a colleague whose kids are into the latest Pokemon Go craze that meaningful use has had more evolutions than a Pokemon has. We've learned that if CMS says it's not going to do something, or it's going to take one direction, just to give it enough time and it'll come around, dragging its feet reluctantly, but meeting providers at least halfway. Ultimately being responsive as best as it can to provider concerns with how the meaningful use stages progressed. A classic example is 90-day reporting, which providers really pushed for every time. They didn't want to do a full year. It was too much of a burden. It was too difficult, especially with all the changes to keep up. And one of the things that we always joke about is that CMS repeatedly said, no, we're not going to consider changes. So in 2014, for example, we had the search extension rule where CMS agreed to, as a result of the delays with 2014 edition final rule, that it would agree to 90-day reporting for 2014 only, but it stated we are not considering changes to the EHR reporting periods for 2015 or subsequent years. For the same reasons, we're not considering changing the addition of start. Changes would put the forward progress of the program at risk and cause further delay in implementing effective health IT infrastructure. The following year, CMS said, wait a second, nope, we're going to give you a 90-day, even though we said we wouldn't. Instead, we determined there's significant potential for a positive impact by reducing the reporting burden, simplifying the program, and realigning the program with long-term goals for advanced use of EHRs. The benefits to be gained from the 90-day reporting period outweigh the potential risk of misalignment introduced by the shortened reporting period if it's limited to 2015. CMS expressly refused to extend this to 2016. So here we are in 2016, and just to also say, look, that stage 3 was supposed to be the final stage, and we've seen already multiple changes. So fast forwarding to 2016, we have our modified stage 2 and stage 3. What it looks like now published is full year reporting for all providers, 90-day only for new and you streamline objectives and measures. So you move CMS considered to be topped-out measures to sort of align better and eliminate attestation burdens for providers by getting rid of measures that it felt hospitals and EPs performed very highly on. It also, instead of having your EP, a hospital set and core menu, it kind of consolidated all of that into one thing. So we see now 90-day reporting has been proposed. The OPPS rule and a proposed rule in July said, despite what CMS has repeatedly emphasized, well, there's a value in 90-day reporting. So for all meaningful use participants in 2016, they would be permitted to choose a continuous 90-day reporting instead of the 365 days that all participants are working to achieve right now. New participants must attest by October 1st, 2017 to modified stage 2 in order for them to avoid a penalty of payment adjustment in 2018. Also, any new participant in 2017 is permitted to attest to modified stage 2 as well, whereas what's currently published is that they must automatically skip to the stage 3 in 2017. CMS essentially recognized, again, with a lot of provider concerns, that new participants just would not be in a position to start off right there with stage 3 if existing participants aren't even at that point in time. Then also, CMS has proposed for there to be a new hardship exception for those EPs who are going to be transitioning over to MIPS. So in 2017, they could take advantage of a significant hardship to avoid the payments reduction in 2019. However, if they took that hardship, of course, they would not be permitted to get an incentive payment, but they would at least avoid the penalty associated with that. Then what's very interesting about the proposed OPPS rule is it proposed a number of changes for Medicare hospitals and critical access hospitals only. It specifically stated that it was requesting comments on the burden to states in having to update their systems to deal with these changes on the Medicaid side, and that it was why it was limiting it to Medicare hospitals and critical access hospitals only, recognizing, of course, for your Medicare EPs, they're going to remain subject to MACRA. So what has been proposed is to completely eliminate your clinical decision support and computer provider order entry measures entirely. In 2017 and in 2018, both in stage 2 and stage 3. They consider these to be topped out. Hospitals and EPs perform very highly on these. So I believe, if you look at the analysis, they said it would save 8 minutes of attestation time to eliminate these from the burden of reporting. They also changed some thresholds in 2017 and 2018, which we'll talk about in the next slide. Of course, this leaves your Medicaid hospitals and your critical access hospitals and EPs kind of stuck with what is currently published, in that they would still have to attest to CDS and CPOEs and stick with the published thresholds at this point in time. And of course, your Medicare EPs are going to be subject to MACRA starting in 2017 unless you see an extension in the final MACRA MIPS rule. All right, so what has changed if this proposed rule is passed as is? For stage 2, it's fairly simple. There's no CPOE or CDS, of course. And then the patient electronic access measure, which gave hospitals particularly a lot of agita, where you had to have a certain number of patients actually go and view, download, or transmit their health information, they've changed this to 1 patient. So they extended what was permitted in 2015 also and 2016 also now to 2017 to make it a little more easy for hospitals, recognizing that they may not have control with their patient population to accomplish this measure. In the stage 3 side, you have a couple different changes here. So a few thresholds have been reduced, notably the API access, which is to make it available for patients to, just to make it available through an API or to access through a portal, has been reduced to 50% from 80%, as well as patient education down to 10% from, I believe, 25%. So it's a little easier to meet this measure for patient electronic access. Coordination of care has also changed, again, extending from the modified stage 2. We see here that it's extending that for stage 3 to 1 patient only has to view, download, or transmit. And then secure messaging is 5% as opposed to, I believe, 10%. So that's also been reduced to make it a little easier for hospitals and EPs to engage in messaging with their patients. And then there are a number of changes to the thresholds reduced for health information exchange. Instead of 50% summary of care for all transitions, that's been reduced to only 10%. Request and accept patient care information, that is reduced from 40% to 10%. And to perform clinical reconciliation, instead of 80%, that has been reduced to 50% for 2017 and 2018. As is classic CMS, they will reevaluate what they're going to do about stage 3 for 2019 onward. And what happens with MACRA and MIPS will obviously influence that as well. So that brings us to what we hope is the meaningful use we need and deserve, which is found in MACRA, which was enacted last year in April. And it sunset the EP payment adjustments beginning at the end of 2018 and established 2 payment tracks, MIPS and then your alternative payment model, which CMS will put physicians into by the middle of 2018, I believe, is the current time frame from it. So for now, physicians may not know whether they're going to qualify for the APM model or the MIPS. So most physicians are going to be pursuing, MIPS requirements until they hear otherwise from CMS. So MIPS makes it a little easier for physicians in that it consolidates what they were required to do under meaningful use, PQRS, and the value-based payment modifiers into one single program. For the better, for the worse, hopefully for the better. What we're looking at specifically is the advancing care information meaningful use piece, but from a MIPS broader standpoint, there are 4 performance categories, so quality, resource use, meaningful use, and then your clinical practice improvement areas. Meaningful use is up to 25 points of the total MIPS score, and again, MIPS is only going to apply to your Medicare physicians and clinicians. Your Medicaid physicians are still going to be on the hook for classic meaningful use as is currently published. However, we do see some alignment between MIPS, meaningful use, and your modified stage 2 and stage 3 as published. All right, so what does meaningful use look like under MACRA? You have a base category here, which comprises 50% of the total ACI or meaningful use score. CMS gives 4 options, basically. First is a primary to choose from, which is a subset of what's published now for stage 3. What's missing is your CDS and CPOE. However, the alternate approach, providers can choose to go ahead and attest to CDS and CPOE if they see the value of that with respect to their organization. So CMS has given EPs the option to either take the primary approach and just do a subset, or go ahead and add in that CDS and CPOE if they choose to. Then, for any physicians or clinicians that may still be on 2014 edition software, they're giving them sort of a modified primary and a modified alternate in 2017 only to allow them to catch up and to get on 2015 edition in 2018. MIPS also, compared to classic meaningful use, removes the thresholds that need to be met. So, for example, 50% of all patients or 80% of all patients. So for purposes of the base category, it only needs to be at least 1. So, for example, at least 1 patient must view, download, and access their information, with the exception of if you take that alternate approach and you do test the CDS, clinical decision support, you need to have 3 clinical decision support rules implemented. You still need to report what your total numerator and denominator is, but you're covered, you're kosher, as long as there's at least 1 in your numerator. What's also different is that the only public health registry reporting that is required is immunization. If you complete 1 or more of the others, you earn a bonus point towards your performance category. So being able to connect to and exchange in other types of data with public health registry is going to get you an extra point in your performance. All right, the performance category. Much like the other 3 general MIPS categories, meaningful use goes from an all or nothing, which you still find in the base, to allowing a little more flexibility here in the performance category to kind of choose your own fate, choose where you want to focus. You get additional bonus points for 3 of the objectives that you are required still to meet for base purposes. That's the patient electronic access, your coordination of care, and your health information exchange. And for each of the 8 measures that are associated with those 3, there's 2 for patient electronic access, and then there's 3 each for coordination of care and health information exchange. They're each assigned 10 possible points. So the higher the threshold you meet, the higher the points that you get. 80% is going to equal 8 points. 95% will equal 9.5 points. So the total possible score you can get here in your performance category is going to be 80%. Now, you're saying, okay, wait, isn't it only 50% of my total, but they're allowing me 80%? Yes. So what CMS is saying that we'll let you get up to 80% because this means you don't have to score at the top for each one. You don't have to get a total of 10 for each one of these. You have some flexibility to focus on some of the other ones and maybe do a little, be a little less robust in terms of meeting higher standards for the others and still meet that 50%. So you still won't get more than 50% for this performance category towards your total of 25 points, but you do have a little more wiggle room there in choosing your measures and how you want to meet those measures. So CMS did sort of back away from that all or nothing meaningful use, where if the threshold was 20% and you were only 18, well, you're out of luck. Sorry, you don't meet meaningful use, you don't get your payment in 2 years, you're getting a penalty adjustment. So they've definitely backed away from that here. One of the other things I should point out here is that if you remember, for your coordination of care and your health information exchange, under classic meaningful use, you can choose 2 of the 3 to actually report the threshold, to meet the thresholds on, and then only attest to what the number is for the 3rd, which isn't the case here for purposes of MIPS. You still have that flexibility, but it's not a pick 2 of the 3. It's here are all 8, you decide how you're going to meet the thresholds. So that there will need to be some careful consideration there for purposes of MIPS as opposed to what a hospital, for example, could do on the classic meaningful use side. All right, so what does it mean for all of you, for hospitals, for critical access hospitals, and especially their EPs now under this new MIPS program? It means that there will be separate attestations and reportings. For hospitals and EPs, there's going to be Medicaid. For Medicare, potentially, there could be some different rules for your attestation. You're not going to test, for example, for CVS or CPOE, even though if you log in to New Jersey's to test on the Medicaid side, you do have to test for them. And then, of course, MIPS has an entirely different method of reporting. There's an attestation, there's electronic reporting for your EMR. There are a couple different options there for how to report for purposes of MACRA and then on meaningful use. So you do need to make sure you're covering all your bases when you go to a test, that you have all the reports you need and know exactly where you need to test so you don't miss one by accident and test in 2 of the other systems. And it does mean different requirements. MIPS, although it does model to some extent your meaningful use stage 2 and stage 3 classic right now, it is a little different in terms of how it's set up and from what's published, and of course now what we're seeing, at least on the Medicare side, for OPPS changes. So what this means for a hospital, for example, is you could have employed physicians who are going to be attesting to MIPS in a clinic, for example, an outpatient clinic, which are going to differ from what you're doing on the hospital side. It also means that if you're a dually eligible hospital, so you are eligible under both Medicare and Medicaid, and you're participating in both programs for purposes of meaningful use, that you have one set that you need to attest to for Medicare, one set you need to attest to for Medicaid, and then you have your EPs. If you have Medicaid EPs, you're attesting to something separate for your Medicaid EPs. Then your Medicare EPs are under MIPS now, and so you have to look to what's required for MIPS. On the EP side, then also you could have an EP who is participating in Medicaid. For EPs, remember that they cannot participate in both programs, but must choose either Medicaid or Medicare. So they could be participating in Medicaid, but then also be eligible under MIPS and subject to the MIPS requirements as well. So even factoring out the hospital scenario, you have a physician who could be faced with 2 different reporting and standards for purposes of MACRA and MIPS and meaningful use. It also means that for physicians, MIPS really begins in 2017. Your performance period for the 2019 payment adjustment is 2017. Since we're not expecting to see a final rule for MIPS until possibly November, that gives 2 months for everyone to get their ducks in a row. Although with CMS's past track record, I would not be surprised if they push back this deadline for beginning MIPS back another year potentially. So the recommendation currently is since what you're looking at is a combination of your meaningful use, your PQRS, and your value-based programs, to really optimize your performance under those 3 programs for now. For the rest of this year, for 2017, if we do get an extension, to do as best as you can in terms of meeting measure thresholds, even if it may be more than what's currently required. Is really taking a hard and fast look at what you can do under those programs' existing structures to help better prepare you for whatever MACRA's final rule may be, and it's expected to be fairly similar to the proposed rule. Notably, there are no meaningful use exclusions for purposes of MIPS. Under Meaningful Use Classic, there were a number of exclusions for each one of the measures and objectives. If a physician, for example, didn't prescribe more than 100 drugs or write 100 prescriptions, then they could take an exclusion from the measure. MIPS has backed away from that and says, well, with this category scoring and flexibility, and we have a general exclusion across the whole program, if you're very low volume clinicians, that should be sufficient. So keep in mind that as you look through what you're doing now for meaningful use purposes, you may not be able to take an exclusion for that next year, and you'll need to be better prepared to meet that measure and objective to the extent there's a corresponding one in MIPS. Hospitals particularly bear the cost of their employed or affiliated physician practices. In addition to meaningful use, whatever it will look like next year on the hospital side, they do need to be implementing and are going to bear a lot of the costs administratively and perhaps purchasing of software to implement MACRA for any wholly owned physician practices or their clinics as well. The most successful organizations that I have worked with have made meaningful use and PQRS very much a multidisciplinary process. It's not just sitting in the vacuum of IT, which unfortunately I have seen also frequently where IT is really the only one, and physicians don't even know that they receive the meaningful use incentive payment. They really have no idea what's going on. The hospital tells them this is the workflow, but may not, associate it with, meaningful use, and really getting them to understand that. And so when you start to incorporate MACRA into that, it's going to be a little more difficult for physicians to make that transition from what meaningful use requires today and what MACRA is going to require tomorrow, so to speak. And finally, hospitals need to get their, and even physician practices need to get their nurse practitioners, their physician assistants, their registered nurse and I always mess that word up, anesthesiologists, and their certified nurse specialists on board. Meaningful use previously only on the Medicaid side could your NPs and PAs attest and get incentive payments. Now under MACRA, those physicians, that void that was there is going to wrap in those other types of clinicians and make them eligible for MIPS, and at the same time requiring them to participate and meet with the requirements. So again, bringing that back to the interdisciplinary, getting that team set up in your hospital or your physician practice is going to be critical to moving forward with MACRA. The good thing is that MIPS does track what's in your, for the most part, what's published, your classic meaningful use for the modified stage 2 and stage 3. It's down to 11 measures from 18. So it does minimize attestation burdens, and it does permit group submissions, which was always a big problem under meaningful use for physicians, in that you could do batch attestations, but each physician still had to individually meet meaningful use. MIPS now permits group submission, not only for the meaningful use side, but as a whole. So a practice can submit under MIPS and avoid the need to submit for each and every physician. And it does move from meaningful use's all or nothing approach, which CMS has been lambasted for years about, that it was not flexible and responsive. It really didn't focus on quality and reducing costs. And now you do see the base category, which is an all or nothing, but now the better you do, the more you're rewarded. And you do see that with how the performance category is structured. And again, for meaningful use side of MIPS, you don't need to have the full 25 points for that section. However, that would affect your performance in the other 3 overall MACRA categories. The CMS, finally heard and responded, and so once CMS has been able to respond to and fully review the comments, we'll hopefully see a final rule that is more reflective of the goal that CMS really is trying to and has been trying to accomplish all along with meaningful use. That is, improve quality, reduce costs, and improve care overall. So with that, I'll turn it back over to Jerry and Ken.
Great, thank you, Krystyna. I think it's great job, and I think it's amazing how much information you can incorporate into such a short period of time. It's great. I can also
Thank
tell
you.
Go ahead.
I was going to say thank you. Yes, I am known for being able to get through a lot of material quite quickly.
Yes, that's a great rep, no doubt. The other good news is that you did such a great job. As of right now, there are no questions, which is also amazing. But as we go through the final slides here for another couple of minutes, anybody out there that has a question, get them in, and we'll make sure that we ask Krystyna before we end this webinar. What you see here is the information. We have our website information. We have information on how to contact us. If you come up with any questions after this webinar, feel free to reach out to Krystyna directly, or you can reach out to us, and we'll make sure she gets the question. So that's great. What we did say is that this is recorded. We're doing these webinars on a monthly basis. So last month we did OCR Phase 2 with Helen Oscislawski. That is recorded and the PDF is available. If any of you missed that, please email us and we'll make sure you get a link to all that. What's upcoming is on a monthly basis, we're going to do third-party security risk management, disaster recovery and business continuity in relation to overall, but also with a focus on the ransomware problems. Functional security risk management program, so, and of course, cyber and medical device security, and potentially we can even think of more. If you have an interest in one that you want us to do, you can email us and let us know what you'd like to hear. So we'll go to the next slide. We want to thank everyone for attending today. You have all the information you need. We're going to get everything out to you. We did it on time, which is great. And so thanks again. Great turnout today. We're very happy to see that. So have a great day. Bye-bye.
Thank you.
Thanks, Krystyna.